No, I don't want to be recording yet.
Hello, everyone. Thanks so much for joining us tonight. Welcome to April's Tourette Talk, Therapy and You, What to Expect in the Mental Health Landscape. I am going to share my screen in a moment to go over some guidelines, but it's like there's a couple other people joining us. Let me just let them in from the waiting room. All right, 1 second. All right, thank you again for being here. So if you're comfortable, feel free to put yourself on camera, but no pressure to. And please stay muted during the presentation portion of this talk, but feel free to send any thoughts, questions, and comments to the chat, and we'll do our best to address them in the Q&A that will start around 7:30. Also, the recording will end at the Q&A if anybody shares any personal information or comes off camera and on microphone. That way, nobody's personal details will be shared in the recording. We have some upcoming events coming up. We will be sharing those in the chat momentarily. Oh, I have our current talk right here. So that's this April Tourette Talk is the program that you are at. After that, there is our April webinar, Rest Easy, Skills to Help Fall and Stay Asleep. We have our May Community Connections online, which is May 12th, and our New Jersey Walks for Tourette Syndrome, as well as our in-person May Community Connections, will be Saturday, May 17th. And our May Tourette Talk is in our own voice, hosted by NAMI New Jersey, or rather hosted by us, but NAMI New Jersey as our guest speaker. And lastly, we have our Tim Howard Leadership Academy in July, late July to early August, and applications are still open. End my screen share. One moment. Sorry, having a difficulty with my computer screen here. There we go. All right. So welcome again. My name is Alina Lawis Osborne. I am the program coordinator for New Jersey Center for Tourette Syndrome, and I'm here to moderate the session and answer any questions about NJCTS programs and services. So we just went over our upcoming events and guidelines. I have a quick disclaimer before I turn the session over. Please note that the New Jersey Center for Tourette Syndrome and Associated Disorders and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented here today. We do not endorse any recommendation or opinion made by any member, presenter, or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. The presenters are providing general information and not any therapy or other health services. Thank you. With that, I would like to welcome Dr. Amanda Ferriola, as well as our other panelists. Dr. Ferriola, if you'd like to introduce yourself and our panelists, the session is yours.
Sure, thank you. So I am Dr. Amanda Ferriola. You can feel free to call me Amanda. I am a licensed clinical psychologist, and I am the director of the Tourette Syndrome Clinic at Rutgers University. And I also work for the Behavioral Science Institute, which is a private practice in New Jersey and New York. And I'm here today with Dr. Michael Friedman, who is a co-founder of BSI, the Behavioral Science Institute. He specializes in anxiety disorders, OCD, also is trained and practices CBIT, which is the treatment for tics and Tourette's, and is a certified in PCIT, and also is on his way to becoming a regional trainer in PCIT. So those are kind of his areas of specialty. And also Dr. Hui Jiang, who worked at the Tourette Syndrome Clinic at Rutgers with me as a student at Rutgers University, and she now owns the 3E Center, and so provides both individual and family and group services as well as neuropsych assessments. So we have a wealth of knowledge here, and so please take advantage of that with any questions you have. Feel free to put them in the chat. You're also welcome to jump in. I'm going to just give a general overview of mental health services in New Jersey and also talk a little bit about the complications of accessing those services and also dealing with insurance. But we're happy to talk about anything that you might find useful. I'm going to go ahead and try to share my screen. All right. All right. So mental health services just refer to interventions, assessments, treatments, or counseling offered in various settings to maintain or enhance mental health or treat mental or behavioral disorders. And so we can do this in individual, couple, family, and group contexts. There are a number of different types of mental health services. So we have inpatient or residential treatment. So this is 24/7 care in a hospital or residential setting. And this is more specifically for people experiencing severe symptoms or crises that require constant supervision. Outpatient treatment is a more common service and the one we'll be talking about most today. So individuals generally attend scheduled therapy sessions while they're living at home, and it's best for people with mild to moderate symptoms and a stable support system. We also have partial hospitalization programs. So this kind of bridges the gap between inpatient and outpatient care. Basically, people go to intensive care facilities during the day and then they return home at night, which is similar overlap or some overlap between intensive outpatient programs. So individuals needing more support without that full hospitalization when outpatient treatment alone is not sufficient. We also have emergency services, so immediate intervention for individuals in crisis situations. This can include hotlines, mobile crisis units, and emergency room services. And we also have community mental health centers. So they can offer a range of services, including therapy, and different types of groups, and they often provide services on a sliding scale, or have income-based services. So when we think about outpatient therapy, um, people struggling with anxiety and related disorders, we can use tics and Tourette's is a neurological condition, but we can treat it behaviorally. So that kind of falls under this category also. But we want to make sure people are seeking evidence-based interventions to address the difficulties they're facing on a daily basis because we want to see improvement with those things. And we have evidence-based treatments to address them. And so it does sort of depend on what the diagnosis is to determine what type of treatment is most suitable. but generally there is an evidence-based intervention. So if you're diagnosed with tics or Tourette's, the evidence-based intervention you want to be looking for is CBIT, so comprehensive behavior intervention for tics. But with any other disorder, it's going to likely follow a similar structure in treatment. So if somebody is diagnosed with OCD, obsessive compulsive disorder, the evidence-based intervention would be exposure and response prevention, ERP, and it would, like I said, kind of follow the same general structure. So when you attend session, there should be some type of intake or assessment process, anywhere from 1 to 4 sessions, depending on how comprehensive the assessment is. And then that would include a feedback and treatment planning session. So a discussion of the goals that you're going to set for treatment, and they should be agreed on between you and your provider. And this should include an anticipated timeline of services. This is always subject to change based on how treatment is going, but you should have some idea about how long treatment is going to last after the intake process is complete. And then you want to kind of have an idea of what the plan is going to be for assessing your progress with treatment. That way you can also judge how it's going, and whether you're seeing the improvements that you're expecting to be seeing. Treatment should also include a psychoeducation component, so an explanation of and a rationale for the diagnoses that are being used, and the proposed intervention, whatever that may be, right? Like ERP for OCD or CBIT for tics, just as examples. And then we want to do the actual intervention. And so with structured sessions, some type of agenda for what the session is going to look like, in session exercises, and then take home practice that's related to the goals that are you set at the beginning of treatment in some way. So for something like CBIT, this could look like it's called habit reversal training. So we practice building awareness of the tic itself and then choosing a competing response for the tic. And so we would actually do those things in session. So we would help build awareness in real time, and then practice using a different bodily movement instead of doing the tic. And then we would send you home to practice doing that at home with a support person that you identify in treatment. And finally, once we look at that plan for assessing progress with treatment and we decide that we've met all treatment goals, there should be a closure. So some type of discharge session, including a plan for how we're going to maintain progress, and how to access services again in the future as needed. So how do we find mental health services? Um, there are a number of different ways to do this. We'll talk a little bit about insurance in the next couple of slides, but you can always start by going through your insurance company. So they should have a behavioral health hotline that you can call and ask for a list of providers, and then you can go ahead and vet those providers after you have that list. Another way is to search Psychology Today. You can filter by specialty, where you live, and then the type of pay structure you're looking for. NJPA also has a provider search. NJCTS has a list of providers that they graciously give people who ask. The Tourette's Association of America also has a list of people who are certified in CBIT. And then the Mental Health Association in New Jersey, you can go to their website, or they also have a number to call, and they help link people with resources. That's true for NJ Mental Health Cares also. They have a lot of behavioral health information and referral services. There's also obviously like the crisis hotlines as needed. This won't get you directly to outpatient services, and we only want to use them in crisis situations, but they do exist. So 988, you can always call or text. They also have a chat, so you can go to 988lifeline.org, and then you can always go to the emergency room as needed. Okay. So when we think about insurance, we have in-network coverage and out-of-network coverage. So in-network coverage really just means that providers have agreements with your insurance company to offer services at predetermined rates. You can talk to your insurance companies to see, generally they have a directory of those providers that they can share with you. So out-of-network coverage, these are providers that don't have agreements with your insurance company, generally pay upfront for services and then seek reimbursement after the fact. So the loophole here is that in certain situations, if in-network providers are unavailable, you can always request an exception. So allowing out-of-network services to be covered at in-network rates. This happens pretty frequently because a lot of the in-network providers are not specialized in evidence-based services. So it's really hard to find somebody who can deliver that evidence-based care that we talked about before. And is in network. So one way to do it is to pay up front and try to ask them for reimbursement after. Another way is to try to get a single case agreement. So it's a contract between an insurance company and an out-of-network provider. Again, that allows the provider to be treated as if they were in network. So we can use this when you can't find an in-network provider who meets your needs. You have a strong existing relationship with the provider who is not in network, or the treatment you need is not readily available from in-network providers. So like the first thing you would want to do is find an out-of-network provider that meets the criteria you're looking for, and call your insurance company and ask to speak to somebody about a single case agreement. And then we would generally, they're going to ask for documentation from you. So you can have the provider write a letter of necessity. So if there's a specific diagnosis and they're looking for a specific type of treatment, that's a great reason to make the argument for a single case agreement. If you have tried other services before and have not seen benefits, that's another, uh, you know, bullet point you can include in that letter. Um, Including a treatment plan of what treatment is going to look like, the provider's license and credentials, generally the insurance company asks for, and then a list of the session costs and also the codes that they plan to use. This is pretty typical for insurance companies to ask for. And then it's just a waiting game. So people get denied and then they will eventually get approved if they keep pushing. So it can be a grueling process, but one that's definitely worth it because good evidence-based treatment is generally it'll generally take less time than care where you're not getting the services that you need. And so, unfortunately, we work in a system where clients need to advocate for themselves, but this is a good way to try to go about doing it and getting that financial support that likely you need because these services are expensive, especially, yeah, outpatient private practice services. All right, so this is kind of a summary of services and insurance and the network we're working in, but we're happy to field any questions that you have about any of this information or anything that I didn't talk about too.
Thank you so much, Dr. Ferriola. So we do have some questions in the chat and that were sent in advance.
Amanda, do you want me to stop the recording or no?
We'll keep the recording going for now, for general questions so folks can see those later. But if anybody wants to come off camera and ask any personal questions or come off mute, we'll end the recording then, out of respect for your privacy. So I can start with reading the questions that we have in the chat and those that were sent in ahead of time. And again, if anybody has questions, please feel free to send them through the chat and I'll read them out. Or you can turn your camera on, come off mute, and ask yourself, and we'll end the recording then. So our first question. One second, let me find it again. Our first question is, do you provide, and this is about the Tourette clinic, I believe, for students with Tourette's at Rutgers, do you provide support for students that are not on the Rutgers main campus?
Yes. Yeah, it's a community outpatient clinic, so anybody is welcome to access the services. But any Rutgers student, regardless of what campus they're on, will get the Rutgers student rate. And yeah, they're definitely welcome to access the services. We provide the services on Livingston campus, but we also provide virtual services as needed, as long as it's determined to be effective after intake.
And I sent over the person that asked that question. I replied privately with the website, the TS Clinic website, so they have the contact info.
Great, thank you.
Awesome, thank you. Our next question that was sent in is, what is the ideal age to start CBIT?
It's a good question.
Wait, do you want to take this one? So I'm not, yeah.
No, Michael, go ahead. Michael is hard. It seems like he already has an idea.
No, you can go for it.
No, go for it, Michael.
I was really going to say that it kind of depends.
Okay.
It really depends on the developmental ability of a child, their ability to kind of increase their awareness of their tics, and to also notice like premonitory urges. I've done CBIT with kids of different ages who were able to do it and who weren't able to do it. Most recently, I did it with a 10-year-old who developmentally was like a little bit younger than his actual age, and he just wasn't able, even after many sessions we were working on increasing his ability to monitor his tics. He just wasn't really able to monitor them based on some delays developmentally, and so even at 10, which you would think is for sure old enough, he wasn't able to do it. So I would say it would depend on whether, as soon as the child is able to or is at a developmental stage where they can monitor their own tics and also notice the urges leading up to the tics, they're old enough to start CBIT.
Great. Great. I'll just add that I completely agree with Michael. I'll just add that in CBIT, there are kind of several components of CBIT. The main, like the thing that Michael just described is the habit reversal piece, which is almost like the bread and butter of CBIT, and that you really needs to be kind of developmentally ready. You need to kind of notice how your body is feeling, or body is feeling, also have the language to describe it. However, there are other like smaller components of CBIT, like functional, training, functional intervention or relaxation strategies, or just the psychoeducation, right? Just to learn what tics are. Would be, still beneficial. So, if you're not sure, I suggest that you start with the clinician. It turns out the habit reversal, they're not ready for the habit reversal. At least they can get these other component undone, and then wait until they're later to do the habit reverse, the bread and butter part of the treatment.
Yeah, it's a great point. We're doing some research on like the rest of the components, because the CBIT is normed on kids 9 and older, and we know tics can start as young as 3, and so that's a really big gap. And so the hypothesis is that all these other components can be helpful at a younger age. And so we're just looking at testing that theory. But I think the more informed parents are, then the younger the kids are, the better. So I think those are definitely important parts of treatment and the process also.
Yeah.
Also, Amanda, sorry, when I was at the TS clinic, we have these groups, group therapy for kids, and so that's different from, we don't do the CBIT or the habit reversal part, but that the group can be really, really helpful for many children, and we have different groups, based on their age, so that's a good service to use as well.
Yeah. As I was hearing everyone talk about this, I'll also just add, along the lines of psychoeducation, I think it could be beneficial sometimes to hear a little bit about some of the parenting practices, which can be helpful. Even if a child is too young to engage in habit reversal, there actually are certain practices or certain things that could be happening in the environment which can actually make tics worse. Even if a child's not old enough to engage in the treatment, reducing those environmental factors can actually be helpful.
Mm-hmm. Yeah, great.
Absolutely.
Mm-hmm.
Just to be clear also, it's unlikely that just reducing the environmental factors will get rid of tics, but it can be helpful though.
Thank you so much. Again, if anybody has any follow-up questions, please feel free to send them to the chat or ask them directly over microphone. We have a follow-up question. Can you give an example of some of those environmental factors?
Sure. Let's say so a child has a tic where they experience some kind of like pain, or it gets like really annoying after a while if they're engaging in the tic like over and over. And let's say the school that they're in is super accommodating, and they will let the child, every time the child's like feeling some pain, they'll let the child leave class and go to this really fun game room where they can play like video games, or read some books that they might really like, or play with some toys. Now, that means that the brain is being reinforced to engage in more tics, get a break to do like preferred activities. And so like an environment, that's like a perfect example of an environmental factor where we think we're actually doing something helpful. We're letting a kid leave class because they're in a little bit of pain, and allowing them to go do preferred activities as a result of ticking or engaging in tics actually associates engaging in a tic with some kind of positive outcome, and that can reinforce the behavior. And so even though it's not necessarily a conscious decision that they're making, they're not saying to themselves like, oh, I should tic more so that I can, my neck will start hurting and I can get out of class. But just the brain created that association. It knows that if math class is so boring, and in the back of the mind, like the brain knows that if it engages in tics and ends up being this kid ends up being in pain, they're going to have an option to go do something that's more fun. So just removing that environmental factor can be helpful. It doesn't mean that a kid who is in pain doesn't necessarily need to like take a break and take a walk and like massage their neck or something, do some stretches, but it just has to be done really mindfully, and making sure not to overly reinforce the tic.
Yeah, I that's a great example. And I think another example we see probably most often is just attending to the tic when it happens. And it's so well-meaning, right? Like you as parents or teachers, or even as adults, especially when kids are first starting out with tics, we don't really know what's happening. And so the questions like, why are you doing that? Or, is something in your eye? These questions inadvertently reinforce the likelihood that they'll happen again, because the saying like any press is good press. Any attention makes the likelihood that the behavior preceding the attention will happen again. And so the best thing we can do for kids is to just kind of pretend they're not ticking while they're ticking. That doesn't mean we have to ignore the fact that they have tics, right? If they want to talk about it with them. Or if you want to talk about it at some point, you can bring it up as a conversation. It's just that when the tic is happening, we just don't want to bring any attention to it, because all it's doing is making it more likely that the tic will recur.
Thank you so much. I just got another question in the chat. 1 second, let me take a look at it. Would you be able, if you can see the chat, it's this is a anonymous question. Sorry, 1 second, I'm trying to comprehend. I think we're gonna go ahead and end the recording now, because this starts to get into a bit personal territory.
Before we do that, can I just jump in and add something to some of the stuff Amanda said that it might be helpful for people to know who might be watching the video?
Oh, absolutely, please do.
So just like circling back to evidence-based, sorry to make that abrupt change, but if we're going to end
No, no
I feel like
problem.
it might be helpful. So one of the things she said was just like you should know when you talk to a provider, like you should have some idea when finding an evidence-based provider, like how long treatment is going to take. I'm just going to add, because I know there's a high rate of comorbidity with tics and OCD. And when you have early onset OCD, or like severe OCD with mental compulsions, sometimes it's really hard to estimate how long treatment's going to take. So I would just keep in mind that that might be an exception to that rule. I'm the first person that would tell you that if your clinician cannot give you a ballpark idea of how long treatment is going to take, that you might be you might not be doing an evidence-based treatment. And as somebody who specializes in OCD and early onset OCD, I will say that that's one of the exceptions. It's really, really hard to predict because it's almost like kids with early onset OCD, they grow up with intrusive thoughts. They never really had moments where they have like kind of, as their thought processes develop, intrusive thoughts are always present. So they struggle even to tell the difference. And sometimes just teaching them how to do that can take like a really long time. And so I would just keep that in mind. But I do think that I think what Amanda was getting at, which is just knowing what to look for, because some of the resources she shared, like Psychology Today and stuff like that, you're not going to really know if you're getting an evidence-based provider, but knowing what to look for, or talking to someone maybe in the field to find out like what questions to ask, like for example, like how long is treatment going to take, what interventions are they using, I think is really great and highly recommended. It's usually what I recommend to people who are asking me, how do I tell?
Thank you so much.
I want
you
to
know-
add
Oh, go ahead.
just a couple of things, just based on what Michael said. One thing I kind of repeatedly get from some of my parents would be, oh, my kid went to therapy for like 3 months or 6 months, and then, it didn't work, right? So, in that sense, therefore, therapy doesn't work for my child, right? So maybe it didn't find the right fit or the right approach, right? That doesn't mean that therapy doesn't work, right? So what you need to do is to go to Psychology Today, go to your insurance page and found another provider. And now you are a little experienced, right? So you know what questions to ask them, right? So just because it didn't work out with one clinician doesn't mean that therapy doesn't work for your child. Another question I often get is that, oh, my kid doesn't want to go to therapy. I know my kid is severely depressed or have OCD or all these very difficult struggles, but they don't believe in therapy or they don't believe in psychotherapy or treatment. What do I do, right? I would love to hear what Amanda and Michael have to say about that. But one thing I often ask these parents are like, what if your child or someone's child, like they trip and fall and broke their leg, right? Then they say, I don't want to go to the doctor. Like I refuse to go to the doctor. Like, what are you going to do, right? You're still going to take them. And you say, this is important. And you say, Mom, I'm going to go with you. Right. And then we'll try again. If it didn't work out today, we'll try again tomorrow, but yeah, so that's like another question I hear often is that, they don't want to go. So what am I going to do? Like, they don't go. So let's just like stay at home.
I think that's a great point. I can tell you my thoughts. I feel like I've talked to Amanda about this, and then happy to hear what Amanda has to say as well. I'll add. I mean, I agree with what you said. I love that analogy, kind of the parent encouraging their kid to try things again, going with them, and things like that. I'll also just highlight there actually are a lot of interventions. Now, CBIT is not one of them, but there are a lot of disorders where parent focused interventions are extremely effective. I just had a friend of mine just reached out to me to get treatment for their kid with ARFID, which is just like extremely picky eating. And I gave some recommendations. And at the end of the day, they said, I don't think I'm going to follow up on any because my kid's not really motivated for this. And I was like, well, I mean, you're kind of the person who buys the food and also gives them their phone and gives them their spending money and basically all the privileges in their life. You have like a lot of methods like at your disposal or things at your disposal that you can use to motivate your child or put them in a position where they don't really have a choice but to try certain things. I'm not saying tell them you have no life unless you do all the exposures in the world. But I mean, there are interventions, there are evidence-based interventions that are parent-focused that allow parents to intervene effectively, specifically in situations where children are not motivated. Again, CBIT happens to not be one of those treatments. But for other things, OCD, for sure, I think SPACE is the name of the treatment that like the accommodation reduction, and it was originally created for children with OCD. So I think you have parents whose children are not motivated and engaged have like a lot of options available to them still. And you shouldn't lose hope as a result. You should seek out like space or some other kind of parent-focused intervention.
Right, that's such a good point, Michael. I really appreciate that point. I would also actually add to it that sometimes you also need to work with school, right? So working with school is actually a very big component. For example, I'm currently working with two school refusal cases, and much of the work is actually not not me meeting with the child, right? Much of the work is me meeting with the parents and come up with strategies, and also parents, me, school have a three-way meeting, so this is also a part of it. So it doesn't necessarily mean that the therapist needs to meet with the child one-on-one every week, right? So it's really depends on, the situation.
Yeah, absolutely. I can echo everything you're saying. I think like the other thing to keep in mind is just the motivation for you also as parents. Because a lot of these disorders, if left untreated, have worse long-term outcomes. And that's really not to make you feel more anxious about the situation, but now while you have more influence and control over the situation, it is an important time to get help and assistance. And anxiety, OCD, school refusal, ADHD, these are all things that have worse long-term outcomes for kids if left untreated for long periods of time.
Yeah, that's a great point. And I would say anecdotally, this is not based on evidence. I don't know what the research actually says about this. Anecdotally, I would say that that's particularly true for OCD. I tend to find kids with untreated OCD for long periods of time have like a harder time in treatment or have like symptoms that get a lot worse over time than even kids with other disorders, which also gets worse. But OCD in particular can get like really bad over time if left untreated.
Thank you so much. I think I would like to ask one more general question before we end the recording and get to some specific personal conundrums. So last general question is, how do you know if a therapist is a good fit for you?
I'm happy to jump in here. Ultimately, if you're getting better, I feel like that's, not everybody is going to agree with this answer, but I have had kids that I've worked with who hated me and who got better. Now, that's not to say it's not better to have a therapist that your kid connects with and likes, but a therapist who your kid loves, who isn't helping them get better, is not helpful. A therapist that they don't like that much, who is helping them get better, is helpful. A therapist that they both like and is helping them get better is the best. But ultimately, you want to go with someone who's like helping you see progress. But I'll with that, I'll see what Amanda and Hui think.
Yeah, I mean, I couldn't agree more. I think like the therapeutic alliance is obviously a very important part of treatment, but it's important so that kids can access the treatment. And really most of the change happens practicing at home, especially with CBIT. So yeah, I would say somebody who is able to do evidence-based intervention is the best thing for anybody struggling with mental health difficulties.
Just add that, so basically in therapy, the clinician should give you at least some goals that they're, pursuing in therapy, and you should see that you're moving towards that goal. And it will be even better if the goal is a behavior-based goal, so something that you can see changed. And then a lot of the time, obviously, we want to be likable. We want kids to like us, but that's not the ultimate goal, right? The ultimate goal is for them to get better. And a lot of the nature of the treatment for for CBIT, for OCD is actually we're trying to help the kids tolerate more distress or frustration. So we're actually deliberately exposing them to a stressful situation so that we can teach them that you're okay, you can handle this, right? So which means the therapy isn't going to be a lot of fun or pleasure, right? And however, that is, what's the best for you, right? So, and this is really important here. I think this is also, I feel like there's much misunderstanding about what therapy is. And people go to therapy think we should have a really good chat and about, what has happened. But while that is important part of it, much of the therapy again is frustration tolerance that you have to kind of really be exposed to that, right? If I have to, I can have a good conversation. I can tell you all you want to hear, but if I make you think, oh, I am very understanding or very compassionate towards you, but if you are not getting better, then I'm not doing a good job.
Yeah. I really like how we put it in the beginning with like the identifiable and measurable goals. Like, I think when I said getting better, like that, you couldn't say it better than that. It's like if you want your therapist to be having clear goals and you want to be able to see progress in that goals. And you don't want it to be like, it's been a year and you haven't seen, the therapist is still telling you, well, this takes time. It's like that's a red flag. If you've been in therapy for, 3-4 months, you should have, you should see progress by then. And even in cases like early onset OCD, which does take a while, you should still see things that are starting to change or have a clear idea of like what's being worked on and how it's being worked on and how your kid is getting better at those things. If you're not seeing any of that, then yeah, I think it's probably the wrong treatment or wrong therapist.
Right. Another red flag would be, oh, like I wanted to terminate this with this clinician, but I just feel like they're gonna be mad at me if I terminate, and that is a huge red flag, right? They shouldn't make you feel that way. Actually, they should have mentioned it themselves if you're not progressing that, it's time to terminate. I can refer you to for someone else who will be a better fit.
Yeah, this conversation actually reminds me of a moment I had in grad school. My first year, I had a professor named Shireen Rizvi, and she was teaching us about a treatment called ACT. And I was at the end of the treatment, I didn't know she was there, but I was talking to one of my fellow classmates, and I was like, I don't know if this is so my style. Like, if I was in a session where somebody was doing this, I feel like it'd feel like weird to me. I don't know if I'd like it. And Shireen was like right behind me, and then she piped up and she's like, "What difference does that make?" And I'm like, "What do you mean?" She's like, "Well, what difference does it make if it feels like it's going to be your style, if it's helpful?" And I feel like that's exactly the idea. You want to do the treatment that's helpful.
Awesome. Thank you so much. We're gonna end the recording now so we can move to some personal questions. So for those of you viewing this at a later date, thank you so much for tuning in.